Now that's me. Good afternoon, everybody. I'm Jim Curran, and Mr. Walker is going to call the roll.
Thank you, Mr. Chairman. Good morning, everyone. Roll call in alphabetical order. Dr. Cheek,
Present.
Dr. Curran,
Here.
Dr. Lane. Present. Dr. Mercer,
Present.
Dr. Rodriguez,
Present.
Dr. Chin, Dr. Ryan Chin.
He probably isn't gonna
muted.
make it.
He's-
He had said he probably wasn't gonna make it because he had to take, I just got an email from him that he was gonna have to take, he started a case.
All right. Dr. Valerie White
Present.
and Dr. Jan, I think, is on virtual, correct?
He was earlier, yeah, his name was in there.
Okay, maybe he lost connection. Okay. That completes roll call, Mr. Chairman.
Thank you, Mr. Walker. I want to, before we go into old business, I want to just say a couple words about what's going on at the federal government level for public health and have us think about some of the implications potentially for the state of Georgia. I think as you know, Dr. Toomey and I both have had a substantial chunk of our careers at the CDC. It has been under a lot of figurative and literal fire lately here in Georgia. I've always been proud that CDC is seen as really the hallmark for the world. A number of other countries have formed their own public health agencies at the federal level, like CDC, and some have even named them CDC. I'm on the board for the French government, and they always look to the CDC for advice and guidance in a lot of things that they do. And the same thing is true for people throughout the world. So it's particularly sad to see a lot of the turmoil and huge morale problems at CDC, which are also present at the National Institutes of Health and the Food and Drug Administration. And it relates to a couple of things. One is the inconsistent but inevitable removal of people from their jobs based upon not so much the priorities as whether or not they can do it legally. So initially, all the people who were recently promoted at CDC were fired because they're called probationary employees. So the ones who were the up and coming best people were all fired, along with other people who were probationary, and they wouldn't allow any transfers between programs. And they still don't allow any transfers between programs. So even if you're in a program and you're an outstanding person and there are vacancies in another program that really needs people, you can't transfer out even though you're targeted to be eliminated. So part of it is just a rather difficult and I think not a good managerial reduction of force, which has resulted in a huge morale problem, which of course was made worse by the shooting of more than 200 rounds of high-powered ammunition into the buildings at CDC. My daughter and many colleagues and friends were in the building and till midnight that day, and they still haven't repaired any of the windows or increased security. So people are afraid to go back to work at the CDC. And of course, they have never had a director in this administration. They had one for 3 weeks and she was fired. Now they have a hedge fund person who's the acting director. So the morale is bad, but there also is a terrific impact on what's going on with vaccines. And as far as I can tell, the major goal is to diminish the CDC role in vaccines in a lot of ways. And by firing all of the people on the advisory committees who were heavily checked for conflicts of interest before being on it and had years and years and years of expertise. and replacing it with people who were largely people who were suing vaccine companies. And therefore, what we can expect is very controversial guidance, which will focus on vaccine injuries more than on vaccine expansion. Many states and many groups are going to start to form their own vaccine recommendations. And Senator Cassidy said that the government shouldn't rely on the CDC for vaccine use. Now, whether that's going to be true for many other things in addition to vaccines, I think we're going to see a lot of things about what people should and shouldn't do during pregnancy related to autism. I think there's a strong anti-pharmaceutical bias, but it's hard to tell how that's going to work out. And there doesn't seem to be a lot of support in any of the medical or scientific communities for the administration, which I think will lead to lots of different people making lots of different recommendations. And we'll be able to, choose from those, I guess, but that isn't the most coordinated way to deal with it. The other thing is there's a tendency to want to reduce the federal budget enormously. And people haven't spoken about, in public health, for example, what proportion of the public health budget comes from the federal government, from CDC. But I think it's reasonable to assume that many people will want to reduce that by a lot. So there could be a big reduction in funding at the state and federal level. At least we should anticipate that could happen because there are a lot of people who want that to happen. So it's a distressing time for public health at the federal level, and it's going to have implications at the state and local level. And it's going to be not easy to predict what all those things will be, but I think we shouldn't be surprised. And maybe this goes beyond this meeting, but I thought I would say that because it's something that's upsetting a lot of us. And the universities haven't come to the rescue for the most part either, nor have too many political officials for reasons that are political, basically. So thank you. Old business, Dr. Toomey.
How about some new introductions?
I want to say something cheerful. What can I say? University of Georgia is undefeated. Georgia Tech is surprising everybody. They're undefeated. Go ahead.
Hey, man, what can I say? That's great. I mean, I'm really, first of all, I don't know if you know that both Dr. Curran and I started out in the Division of STD Prevention a long time ago. You a little longer than me. But
I'm really old.
So am I. But anyways, I wanted to introduce a couple of new staff because one of the perhaps I think the positives for me are working with new people, and in challenging times, it's always great to have a new set of eyes looking at the challenges we're facing and helping us think through how can we reframe these issues in a way that we can do a better job, potentially as Dr. Curran said, with less funding. How can we actually create an opportunity to improve the services and better focus them on what we need? Kind of like, to me, the home visiting program did, because it really identified a need, used the data from the state, and then focused that energy on creating a program that best met our needs. That being said, I think you've already met the new chief of staff, Chris O'Connell, who's been here for a number of months. But I have two people that may be new to you. I first want to introduce Daphne Skandrick. Daphne has here joined us as our new state registrar. Now you're going to ask, what is the state registrar? And I think what is really interesting is we had a study committee a couple weeks ago with the House, many in the in-house leadership, and one of the members said, well, public health gets you coming with the birth certificate and going with the death certificate. And when you have major life events in between, it's vital records. it didn't count the public health lab, which is newborn screening. But I thought that was one way to get you coming and going. And you really need to have a very good, articulate, savvy person in that role, because that role requires not only an understanding of the mechanisms of how those vital records work, but also interpersonal skills, because you're dealing constantly with legislators and others who need their birth certificates or death certificates when someone passes in their family, and all these other things that are going on now, including getting your passport, etc. And we were advertising for a minute, and I was so pleased that we poached someone from DCH, which is, and unbeknownst to me, there was a gem hiding out in the Department of Community Health, who've been working on many data issues and been representing us in the state on the GHIN, which you and I have talked about a lot, Dr. Cheek, and was actually the member on that, chair of many governance committees. And you may want to talk a little bit more about yourself, but she held the position of the executive director of the Office of Analytics and Program Improvement at DCH. And so she was working on data and understanding how these fit together, including our vital records. And I think all of us, when we interviewed her, went, this is tremendous. We really think this is a great opportunity to rehome her in the same building, but in a new role. And I thanked Dr. Burke for his generosity, but we stole her away. And please meet Daphne Scandrick, our new vital registrar.
Thank you. Thank you for the welcome. I appreciate it, Dr. Toomey. 3 months in, and I still love it. But as Dr. Toomey mentioned, data is a big passion for me, and process improvement. Those were the areas that I worked a lot in at DCH in multiple roles for 25 years. I definitely did not expect to be just at DCH for that amount of time, but I always wanted to stay in state government. So when this opportunity came, it felt like it was the perfect time to make a change. And there's been a lot of things happening at the State Office of Vital Records, a lot of great opportunities. And so I'm looking forward to being able to make a mark and really bring the state office to the level that it should be at.
And until you need your birth certificate or your death certificate or some other, you don't realize how important that vital records is, and that kind of customer service and the access and what an important role it plays. And I just thought that's one of the many silent things that public health does for Georgia every day. And you may not realize that until you need to engage. But we're just delighted you're here, Daphne, and thank you so much for joining us and for meeting everyone. Because I was afraid you might not meet her otherwise, unless you needed to get a copy of your birth certificate or something. So that's great. Well, thank you so very much.
So let me ask you, so I'm so interested in that. What's your educational background that you get to this level of data?
Undergraduate in computer information systems.
Okay.
Yep. And quite honestly, full transparency, I had my daughter when I was in college, and so going back to school really wasn't an option. I had to make that undergrad work, and I developed a lot of analytical skills, with my programming background, and data just became important to everyone. And so I just, continue to work at it. I think personally, I really believe in building good teams. And that's something that I did at DCH a few times. I set up a few different offices for them.
And are you from Georgia?
I am. My father's military. I was born at Fort Borden.
Okay,
Augusta.
good, Augusta, yeah.
Yeah. So, roots here, and just, again, really happy to be a public servant and glad to be here at DPH.
Many of our health departments have vital record sort of satellite offices, but the main office building is over in Phoenix Boulevard. south of the airport, and it's really quite an impressive operation.
We should have a meeting there one time.
Well, I was gonna say, we have two impressive operations today. One in Vital Records and the other in the Public Health Lab. And so that
We did
is,
the lab.
We've done
We went
that.
to lab.
but you haven't met the new director
Oh,
who's sitting to your side.
yeah.
So which leads me, notice that slick transition from great opportunities to visit Vital Records and, as you already know, our lab. We haven't had a permanent lab director for a number of years. And we've been recruiting, and I had heard about Dr. Ellen Kirsch because she, like Dr. Kerr and I, was working in that field of STDs. When I was an EIS officer years ago, they just started the gonorrhea isolate monitoring project, which was housed within the CDC STD laboratory. And Dr. Kirsch had been the director of that STD laboratory at CDC, and I'd heard a lot about her. I reached out to her, I can't remember who reached first, but we both reached out, recognizing we had some common background, great interest, and an opportunity on Claremont Road to recruit some wonderful leadership. And Ellen, you do a much better job than I do. Dr. Kirsch, you do a much better job than I do introducing you, but it is just a pleasure to have you on board as well. And why don't you just say a few words about yourself?
Sure, thank you.
You'll be talking later, but this is intro time.
Sure. So thank you for the opportunity. I've been so impressed with the breadth of the program and the opportunities here. So yes, I come from the STD and HIV programs at CDC. I've worked for 18 years. Before that, I did a postdoc with Rafi Ahmed at Emory University, and then also a few years as early faculty. I figured you must know him. So basically, infectious diseases. I'm originally from Germany, where I got my undergrad and a master's degree at the Free University of Berlin. I was very influenced in those early days by the late 80s and the AIDS epidemic. Worked in a hospital for a while, considered medical school, but then really found a passion for public health, research, and infectious diseases. So yeah, I'm excited to be here. It's a wonderful opportunity. The Decatur Lab is an amazing opportunity and operation. I can't wait to tell you all about it in my slides, but I'm really looking forward to working here with all of you to figuring out what Georgia really needs. I don't come with a specific, must do STDs or must do whatever it is that
You must do what you must do.
whatever the needs are. So we're definitely open to input and orienting us towards the next phase of this laboratory.
And Dr. Mercer and Dr. Cheek are I call them the
Old ladies.
No, it's like you have helped to nurture our newborn screening and expand our opportunities there. They've been real leaders in helping us do that and advocating for us to do that.
Thank you.
You call them your reliable, wonderful pioneers.
Pioneers. That's a new, someone asked me, I said, I called myself
Pioneer.
vintage. I'm going to say I'm a pioneer. I like that better. It sounds like Annie Oakley or something. So that's good.
Did you say any of them?
Yeah. I was a cowgirl when I was little. So, anyways, that's all I got on this side. Thank you both for being here.
Should we go back to approve the minutes?
Why not? Sure.
I mean, geez, details.
It was not on the agenda. I don't know anything about it. Yeah. Do we have a motion to approve the minutes or amend them?
I'd like-
Second, anybody?
Second, okay, motion carried. All in favor, say aye.
Aye. Thank you. Now we're going to new business. And we've had the introductions already. We're going to Dr. Drenzik, who will tell us what we need to know.
There's so much going on. We don't even know
I
where
know.
to begin.
Thank you so much, members of the board, Commissioner Toomey, colleagues. Glad to be with you this afternoon. what we're going to talk about is a little different than usual, but it is a very interesting situation that has garnered a lot of media attention recently. So we thought we would tell you a little bit about something relatively new. So next slide, please. So as you have heard me speak for many, many years now, when we're looking at the universe of infectious diseases, they really are ever changing and unpredictable. And one of the characteristics of infectious diseases that make them so unpredictable is this characteristic that when you're looking at this universe, everything old is new again. Things that diseases that have been formerly eradicated resurge, outbreaks occur. So no matter even if we are complacent and we think that we have disease situations under control, they seem to pop up again. So we're going to talk about one in particular, and this is called New World screwworm, which is a parasitic infestation. And this again, you may have heard a bit of this in the media over the last few weeks. It's getting a lot of attention. And I'll also mention that everything, like even as old as influenza, can also be new again. Every single season, it can look different. So we want to at least, sort of remind ourselves as we're approaching flu season, some of the important prevention strategies to think about. And rest assured that no matter what resurges, what emerges in a new fashion, or what is continuing in an ongoing basis, we will always use surveillance and epidemiology really to point to our targeted prevention and control strategies and recommendations. Next slide, please. So in dramatic fashion, as is typical, one of the headlines last week said, human case of flesh-eating screwworm reported in Maryland. And so to understand why a human case of this parasitic infection is important now, I think we need to take a step back into its history and where this particular type of disease stood historically here in this country and in the Americas. So let's go backwards before we go forwards. Next slide, please. So what is New World screwworm? It's actually a parasitic infestation, and it's of very significant historic importance in the Americas, North America, Central America, and South America primarily. It's primarily a livestock disease that affects livestock in a very, very significant and severe way, so causes very significant economic losses. But it can also affect humans and other animals. The disease that is called a myiasis, and it refers to infestation of healthy tissue or wounds or mucous membranes with larvae from a particular fly that you can see here on the slide. It's visible. This particular fly is called Cochleomya, and it is also it is not found here in the U.S. currently, but is found in other areas of the Americas. And this particular fly, again, and this particular infestation of both livestock and occasionally humans is resurging again. So why is it called screwworm? If you look at the picture on the slide at the bottom, on the right-hand side, this is a larva or a maggot from this particular fly, from the eggs that are laid. And so it looks like kind of like a screw-like appearance. It has sort of a flat top and it tapers to one end. And it actually kind of burrows into wounds, kind of like a screw as it's going in. So these flies lay hundreds of eggs into wounds or mucous membranes, and then they hatch into these larvae, which cause severe damage and even death. And if you think about this as primarily a livestock concern historically, you realize that this can really cause very, very severe tissue damage, affecting livestock, and can also cause secondary infections that can even lead to death in these animals and in people as well. Okay, so next slide, please. So where is this found? Where do we actually find New World screwworm? If we take a step backwards and look at its history, it really has been found historically throughout the Caribbean, Central America, and South America. It actually was first recognized in North America, in the US, in Texas, in the mid-1800s. So it's been around a very long time. And it was primarily a condition and a disease that affected wildlife. In the 1930s, some infested cattle with the flies were translocated to Florida from Texas and caused a really large outbreak in the 30s in Florida. There was such severe economic impact and economic losses that the USDA again, in the 1950s, developed really they pioneered this technique in order to try to eradicate these population of flies, which is called the sterile insect technique. So they essentially irradiated these populations of male flies. They grew them in a, essentially in a factory setting, irradiated them so that they were sterile, and released them back, either via a plane or from the ground. And then this was in the 1950s in Florida primarily, so that these flies can no longer mate. So they're sterile, so they would reduce the fly population. So this is what they called essentially kind of a biological barrier. So they didn't use pesticides or insecticides, to try to reduce fly populations. They did it through this biological barrier where the flies were sterile. So this actually successfully eradicated the fly populations and screwworm from the United States in the 60s. And then they used the technique, sort of moving all the way south through Central America. So Mexico in the 80s, Central America in the early 2000s, and then they basically stopped at Panama. We still see New World screwworm in South America a lot, but really it had been eradicated and pushed all the way down to at Panama and the Darien Gap, where this biological barrier has existed, again for 20 some years. Next slide, please. So now what's going on? Of course, everything old is new again. Over the last couple of years, this biological barrier essentially was broken in the sense that the New World screwworm flies, with its subsequent, cases of disease in both animals and humans, rose back up through Central America, beginning in 2022, all the way up through Mexico in 2024. And there have been, even in Mexico as an example, even as of this year, there have been 40 plus human cases of New World screwworm in Mexico. So the concern is we have not seen New World screwworm here in the US in a long, long time. There was a very small outbreak that was contained to the Florida Keys in 2017 among key deer that was again eradicated and stopped using the sterile insect technique just on one of the keys in Florida. So we really are concerned now. USDA is concerned. Public health professionals are concerned. We do not want New World screwworm to continue its northern path forward, up into Texas or anywhere else in the United States. So the USDA and other partners have really taken over the last year or so a very coordinated and strong approach to try to keep New World screwworm, sort of out of the US and kind of to move it back, if you will, even down to South America. Next slide, please. So from the public health side of things, what are we worried about? Well, we're worried about human infestations with New World screwworm, basically among US travelers to areas where it's endemic, like South America or Central America or Mexico now. So there have been 3 travelers in the last 10 years that have returned to the US with screwworm infestations after traveling, on vacation, either to the Dominican Republic in 2 cases. One traveler had returned to Arkansas from Argentina and Brazil on a trip. And the problem is that if travelers return to the US with this infestation, with these screwworms, the larvae in the wounds that they have, it's possible that the fly population, can resurge here in the US. They basically are bringing flies back here to the US, which poses a risk then, not only for the individual that is dealing with the infestation, but for subsequent transmission to livestock here. So it's a twofold concern. When they looked at these travelers, and this is another common theme, right, with infectious diseases, is that our travel-associated cases of infection or infestation that bring these diseases back to the US. So in the case of these 3 travelers that over the last 10 years, the risk factors for their infestation included having existing wounds, primarily on their face. One had it on their ear. They were sleeping outdoors. They had a lack of bite protection or coverings, and one individual had existing immune compromise. All of these individuals, once they came back to the US, had extensive tissue destruction and required surgical removal of each and every live of larvae. And so that's the problem as well, is really like getting all of these larvae removed and essentially killed so that they are not, being able to grow, hatch out, transmit this disease and build up the fly population here in the US. So there's a lot of disposal recommendations for these larvae. They have to be put in 70% ethanol. They can't just be like thrown away. So you have to sort of track each and every one of them. Fascinating as well. So next slide, please. So that happened over the last 10 years. And now last month in August, there actually was a new case of New World screwworm that occurred in a resident of Maryland. And he had returned from a trip to El Salvador. This is, again, in Central America where the New World screwworm outbreak is resurgent. And so coming back and seeing a wound, of this nature, it's important to have the proper diagnostics based on the larvae morphology. You want to really make sure you're dealing with screwworm and not another type of a fly larvae like bot fly. So this case patient had the same sort of treatment, surgical removal of all larvae, followed by appropriate disposal, wound debridement, wound care. So right as this occurred, because it's such a concern for livestock in a given area, out of an abundance of caution, the USDA initiated surveillance within a 20-mile radius of where this case patient lived to look for flies, to look for and trap flies to make sure that they're not, again, the screwworm fly that is here or that has, that has grown. All traps were negative. They did not find any evidence of any further spread or transmission, and there was no livestock transmission detected as well. So that's good news. They feel like it's a very singular, sort of isolated case, but it raises, again, the specter of being aware, both as a healthcare provider, as a traveler, and again, for livestock producers as well, that this is something that we, even though it has been eradicated in the US many, many, many years, can still occur and travel back here to the US with humans that are exposed in other parts of the world. Next slide, please. So if we think about prevention as our, kind of the it's paramount, it is preventable. So this recent detection of New World screwworm in the US serves as a reminder for all of us in public health, healthcare, livestock, USDA, regulatory agencies to maintain vigilance. It is not just, something that occurred 50 years ago that we never have to worry about again. And certainly we have many, many travelers in the US that travel to places in Central America, in the Caribbean, and South America. And so it's just a reminder there to, keep, if you have an existing wound, keep wounds covered, wear, the kind of the usual, sort of insect bite prevention strategies, long sleeve shirts, pants, use EPA registered repellents, avoid sleeping outdoors or sleep indoors, or use bed nets, depending on where you're traveling. So again, just kind of recognition and surgical removal of all live larvae so that they can be appropriately disposed and not, kind of get out during travel or during transport or going back home. That's really the key. And just as an example about, one prevention strategy that is on the USDA side, again, just in the last couple of months, USDA announced that they're so concerned about New World screwworm coming up through Mexico into Texas that they're going to have started an initiative to build a whole brand new, state-of-the-art sterile insect dispersal facility at an inactive air base in Texas. Fort Moore, I think it's called. So again, this is just kind of another layer of barrier of prevention. There is a lot of thought, well, why is New World screwworm moving back north again? If it was eradicated for so long, they really don't know precisely why. It's just there's probably multifactorial, but it primarily has to do with movement of animals. Either, sort of outside of the normal ways of doing things or outside of regulatory ways of doing things, but it's usually from movement of animals. So that has also been stopped over the summer as well, where cattle cannot be, sort of imported from Mexico to the US as well. That's one other strategy. So it remains to be seen, sort of as we can, sort of build this barrier against New World screwworm. But in the meantime, CDC even today sent out prevention messaging to healthcare providers, just to say, if you see something like this, the most important thing to do, is you consider it, make sure that it's appropriately diagnosed as screwworm, and make sure that, again, these larvae are handled appropriately. So more to come about that as well. So now let's shift gears very, very briefly into what our next, everything old is new again. And that's, what do you think flu season is going to look like this year?
Okay, did we ask questions about
Oh.
screwworm?
Oh, sure. Do you want me to stop there? Okay.
Yeah.
Okay.
I mean, screwworm is real different than flu.
So how large is it? Is it as large as what we call the larvae, the maggot? I mean, is it that visible in a wound?
Yeah, it's visible. They're about 10 millimeters, say between 6 and 17 millimeters. Yeah, there's hundreds of them in wounds.
And we had a case here a few years ago, right?
We had a traveler that ended up in Georgia as well.
This got some national attention when this happened, and I being a cowgirl, I did have a horse for a while, and we used to worry about bot flies. We're always trying to remember and that sort of reminded me of as human bot flies.
Yeah, it's similar. It's the horse bot flies and there are other bot flies too, for sheep and Cuterebra and cats and things like that. So yeah, the flies, sometimes there's another host in between. Like for a horse bot, the fly eggs actually end up in another arthropod that bites the horse, and then the eggs get on the
So they're intermediary.
Yeah. And is primarily humans can get horse bot too, but very rarely.
It sounds like the the serious infections are quite evident. But are there minimal infections or even asymptomatic infections in animals or humans? I mean, that would be a frightening thing.
Yeah, usually not. So we wouldn't want to say it's a good thing that the wounds are this severe, but they really are.
They have to present.
Yeah.
So if you find an animal in a herd with this, you don't have to kill the herd.
No.
You don't have to inspect the herd for everything.
No, it's not transmitted, sort of animal to animal, it's individually, but, so it's the loss of, they get so sick, it's a loss of sort of, the muscle deterioration in these wounds are so severe, you certainly can't, sort of use the livestock as food animals, so.
So unlike a lot of organisms which are named in unrememberable ways, this is a memorable
It is.
term. I mean, it scares the crap out of you. to
Yeah,
think about it,
yeah.
Without even knowing about it.
The species name of the fly is actually translates to man eater too. So yeah, so they're all kinds of memorable names.
It's hard to get people excited about Neisseria, but screwworms, they can get excited.
So let me ask you a question now. So in the beginning, we talked about the screwworms, but you talked about flesh-eating bacteria. So is this a part of that?
Oh, no,
Is what happened?
the headline said flesh-eating parasite. So, yeah, so it's different. This is a parasitic, or it's a parasite that, again, the larva itself is an obligate parasite. It won't live unless it's eating flesh,
Okay, so.
for lack of a.
So to make sure that I understand this, so these people that travel to South America or wherever, they have a wound already that's open, uncovered.
Correct. They have a wound already, or it can also end up in a mucous membrane. But usually they have a wound already.
Okay, and the fly lands on it.
Yeah, fly lays the eggs and then the larvae grow.
And it
Like the
grows
one-
inside.
Yeah, like for example, one of the cases earlier from a few years ago, the wound was, it wasn't, the fly landed in the person's ear.
And it could be a little
You're
like a
gonna
mosquito
pull me
bite.
off stage soon, right?
No, I'm fascinated by this, and I'm just counting on the fact that we'll never see this here. I hope. But I think the wound could be something small, like another bite or something,
It can be
or
small.
scratch.
It won't be small for long.
But you're right, that catch of flesh-eating bacteria, which has become a popular.
Yeah, there are a few of those out there too, but this is different.
This kind of, sorry, I won't tarry too long, but this reminds me of a doctor down in Florida that's an ear, nose, and throat doctor. He had a case where fishermen, you know how fishermen go out on the boats and they fish all day and they handle the fish and the bait and they
Yeah.
eat their food and all this type of stuff. Well, this guy started to have issues, like in his brain, like where he was passing out and it was starting to have blood and what have you. They ended up going here and he found out that some maggots, so to speak, had gotten up through his nasal cavity and began to multiply and lay more eggs and started to eat parts of his brain inside. And he had to go in to pull them out, so to speak,
Wow.
because they tried a suction device and that wouldn't work. And he had to literally go in and open up and pull those out. And that was because of him handling all of this raw food on a ship and not washing his hands.
This is like aliens or something. This is what it feels
Yeah.
like to me. Where's Sigourney Weaver?
TV show.
Yeah.
Well, flu really does kill us.
Who does really kill us? So I really only
And
have
we are
one thing, I
like-
only have one thing to say about it, because we don't know what our flu season will be like. And this year, and the good news so far is we've had minimal flu activity. It doesn't look like it's a very early start to the flu season. Sometimes we have them starting in August. So it's just a good reminder that this is the time of year, September to October, to be sure that that we get our flu shots.
How about COVID?
Yeah.
Well, how about it?
I think we've actually seen some increases in COVID activity in the summer. That's been consistent for every single summer. So I think that normally what we see is this like late summer it's a little bump in COVID activity, and then we see another one that usually occurs after the holidays. That usually occurs January or so, late December. So again, individuals that have that are at risk for severe outcomes of COVID should ensure that they remain up to date on vaccination in consultation with their doctors, and as has always been the case.
Is the new variant covered in the current vaccine?
There will be a new, so all of these variants, even the newest ones, are all Omicron derivatives. So even, sort of the previous vaccines would will be effective against them. But the new formulation for this coming season, the newest COVID formulation will be reflective of the most recent variants.
They've been approved by FDA already.
They have been approved by FDA
And
for some populations.
now the new variant has been linked to a different symptom complex in some people. You want to say anything about that?
Yeah, there are the most two recent COVID variants that we saw over the summer that began in other parts of the world this year. These two variants actually had one of the sort of characteristic symptoms for both of them was a very severe sore throat, and it's like in the media they like to kind of exaggerate these words a bit, and it's called razor blade sore throat.
And I think it's true, only because I've been looking into this, that Novavax has not been updated. But the mRNA vaccine.
Yes.
MMR, okay.
Yes.
So the Moderna and Pfizer. Yeah.
And are they still being covered adequately by third-party payers and
Well, I think that
government payers?
it's just at this time of year, I think it's not well characterized yet.
And it's pending, I think, what's going to happen in a couple of weeks with ACIP.
So CVS and Walgreens have the vaccines, but they aren't releasing them yet until they get approval. And then that was supposed to happen this week. And then if you have a doctor's appointment, but if you're over 65, you're supposed to be able to get it without a doctor's appointment. And then the question is whether insurance companies will change what they do. Probably not for people over 65 and who can demonstrate that they're immunocompromised. Part of the problem has been what it takes to demonstrate you're immunocompromised. And if you don't have it available for everybody, then, somebody with diabetes, for example, has got to find a doctor to do the prescription. And the whole idea that everybody has a doctor that you can just go to is not true. And so, will Medicaid pay for it? Will Medicare pay for it? All these things are.
Dr. Curran, in your remarks earlier, you made the comment that the CDC would no longer be looked upon as maybe an expert for vaccines or something like that. So,
Well, that's the fear. And that's what Senator Cassidy said, until, in other words, they shouldn't be trusted until proven to be trusted. Essentially, and the vaccine advisory committee. So you have the FDA approve these vaccines. Usually what happens then is it goes to the CDC advisory committee to make recommendations on their usage. The CDC advisory committee has been disbanded, but then it's been reconstituted by Secretary Kennedy with people many of us think are very poor choices, because many of them are suing vaccine companies, and et cetera. Now, they could add more people, maybe that would be qualified. They're going to be making some recommendations, not just on COVID vaccine, but on RSV and flu vaccine, and maybe eventually hepatitis B vaccine, which Kennedy doesn't particularly like either. Because he's made a lot of money suing Merck for hepatitis B vaccine. So it's all up in the air until it's not. And I think one thing to look at is what the American Academy of Pediatrics and other professional organizations do. If the American Academy of Pediatrics endorses whatever comes out of CDC, then I think that's probably a good way to trust it. But if they don't and come up with their own recommendations, then the question is, will insurance companies cover that? And I like to be an optimist about these things and say that I think they will, but I'm not sure. I think having people having to get a doctor to recommend it really takes away one of the breakthroughs. And one of the breakthroughs is being able to walk into these drugstores and get a flu shot and a COVID shot, and they can get them at the same time. And so that makes it real easy. And if it's free, it makes it even more easy. But if you take that away, then and the thing that people who worry about are the immunocompromised people. I think pregnant women, but that's another issue. And all immunocompromised people at all ages. But a large number of us have a chronic condition if we're under 65. Even though we don't really think of it, like diabetes. Oh, that's not bad. Yes, it is. If you get COVID. And I've had a couple of friends already older friends hospitalized for COVID at Piedmont this year for 7 or 8 days. And, they shrugged it off, but, I thought they were going to die. And if you're in a hospital, you're 80 years old, and you're in a hospital for 7 or 8 days with pneumonia, it's touch and go.
Well, will there be a bigger role for the Department of Public Health if things continue to go the way that we hope they don't go, where we will have to become the voice of reason for people here in the state of Georgia, for instance?
Well, there's some competing there's some competing groups that are looking to analyze and provide advice. One of them is the Vaccine Integrity Project, which is headed out of Minnesota, University of Minnesota. California, Oregon, and Washington are banding together to do some of these things. Massachusetts is considering to do this. So I think you'll see state and local health departments step in if needed. But the data's got to be available. I mean, the problem is updating things. And I think also keeping track of adverse events is extremely important. Now, Kennedy's very interested in that. So I think we'll see a lot of adverse event information come out. But the question is the perspective of it. There are already a lot of adverse events due to COVID, but they're not as bad as the adverse events due to the infection. And that requires a lot of professional judgment rather than legal judgment. I mean, if your career is based upon getting compensation for people who have adverse events, that's not perspective. I mean, that's one perspective. And that's sort of where we're coming from. And that's a dangerous, in my view, a dangerous approach in medicine and health. And the thing is that if there's been anything to unite medicine and public health, this is the best, I think.
Thank you.
How long is a flu vaccination, how long does its immunity classically last typically?
It wanes a bit each, sort of month after receipt.
So it'll peak within 2 weeks, it'll start within 2 weeks of injection?
Oh, right. Oh, I see.
It'll
So
start in
you're
2
asking
weeks.
how long does it take to?
No, it'll hit about 2 weeks and then it'll wane at how much?
It wanes a bit each, sort of month after vaccination, maybe 8% or so. So sometimes when they talk about kind of balancing, not getting it too early,
Yeah.
because you might have a late, sort of a spring surge or something like that. But you'll you still would have anamnestic immunity, you still would have a response if you were exposed to flu, but it does wane a little bit over the months.
So with that anamnestic response, what if a person got a second flu shot forgetting they had gotten their first one? Sometimes when you walk in the pharmacy, they'll have so many people that say, well, I think I got it. I'm
Yeah,
not sure I
yeah.
got it. Well, maybe I got it. What if they got a second one? Are there known complications?
No, not that I'm aware of.
Me either, okay.
And one thing too, we've always thought, and the fact that maybe it doesn't match every year, but if you
Right.
get consistently one every year, then sometimes you may have matched from out of the past or some type of, residual immunity. So I think it is important to just yearly get your flu shot. And over time, like I said, if it's not perfect match there, you probably have some immunity from out of the past.
So there's not a reported on a repeat shot that we know of.
Probably, they give bigger doses to seniors.
They
And
do,
so,
same
and so it
thing.
probably is not
Right,
going to
yeah.
hurt you, I would say, but that's not scientific.
And I think it's really, I think people forget how many people die every year in the US and in Georgia of influenza.
Absolutely.
So I think it's a good
The reason
reminder.
I ask that, you have so many people that they have their yearly checkup and, well, you're here, let's go ahead and give you your flu shot. Well, it's, that's like in June or July.
Yeah.
They don't want them back in the office anymore. It's inconvenient to come back. And I've talked to a lot of people, I've already had my flu shot. I got it in July,
I think the public doesn't understand enough about the similarities between COVID and flu. They always think about the distinctions between the two. And basically COVID, the United States has benefited from our experience with COVID. I'm talking about biologic experience, because so many people have been infected, so many people have been immunized, that we have some immunity to even new strains. And also the vaccines really work a little bit like the flu vaccines, except they're probably a better match, but they basically prevent serious illness. And that's one thing that flu vaccine does. It's not so good at preventing influenza infection, but it's good at keeping you out of the hospital and keeping you alive. And that's the same thing is true for COVID.
Right.
And to minimize that, as some people in the public media have done, it doesn't prevent transmission. Yeah, but it prevents people from dying. And I don't know how many people remember when I was the dean, every single ICU bed in Metro Atlanta was filled with COVID patients, and people were dying all the time. And they weren't people that
People
were
forget
falling apart. They might have underlying condition, but they're
Now, is there an economic drive though to continue to update the COVID? Are the pharmaceuticals economically motivated to do that?
I mean, I think the risk is, if you go back in the old days before there was mandatory vaccine, not only coverage, but mandatory vaccine coverage for the pharmaceutical companies to get sued, then nobody made vaccines. So if the companies start to get out of the business,
Yeah, that's what.
then we're in big trouble.
Yeah.
And the Dr. Lattipos of the world will be driving that. If you don't have to get a vaccine, and if you are going to be threatened with a lawsuit with everything, then and there's no caps on the lawsuit, and there's no federal money put into the vaccine effects, then the companies are going to say, I think we'll make cancer drugs.
That's what I think.
Yeah, and that's a really dangerous thing. And it's not something that everyone worries about.
I just would like to mention when we were healthcare professionals, we were the first on the line and we were the first in line to get the vaccines. And most of us had the opportunity to participate in the CDC's ongoing, did you have side effects from this? I was a questionnaire. I mean, I got it for 2 years because I was, we were as healthcare professionals, we were on the front line and we were there and we kept getting all these repeat vaccines. So the CDC, I think, gathering that data of people that were really fresh getting the vaccine and how we lived through it or didn't live through it, or did we have a complication? Just the opportunity to have those kind of data available up front and have a mechanism to have it happen is
I think
really was transformational.
I think the NIH studies on long COVID have been canceled. So, a lot of things, like a lot of chronic diseases, all the autism grants were canceled initially too. I mean, ironically, a lot of the things that were supposedly our
Fighting
priorities
against it.
are being, all the research is being canceled on. You know, the major causes of chronic disease, major chronic diseases are still heart disease, cerebral vascular disease, cancer, diabetes, and they aren't being mentioned. What we're really listening to is concerns about ultra-processed foods, environmental contaminants, and misuse of pharmaceuticals as the major cause of chronic disease in the United States. Now, you know, I think processed foods may have something to do with the obesity epidemic, but you know, we canceled all the smoking programs, cessation programs, we canceled a lot of the substance abuse programs, we canceled all the violence prevention programs. And so a lot of things that are actually killing people are being canceled, programs to prevent that. And we don't have a chronic disease secretary. We have a processed food litigation person, and who doesn't understand autism. Not that it's easy to understand.
Were some of our Ron White funds protected
Say that
in
again.
the state? Our
Right.
if-
For now, our HIV, even our HIV prevention has been sustained on the federal side. But as Dr. Curran mentioned, the smoking prevention monies were stopped by CDC, as well as a number of other things. And so I know the narrative was that we were going to lose all of our HIV money. That hasn't happened. It's actually been
we've lost
good.
smoking, which affects people.
Well, and it affects
Smoking kills
people,
a lot more
whether
people
with
than red
HIV
dye.
or HIV or not, but, so anyways, but I think getting back to your point, Mr. Walker, I think what's happening is we don't know what's gonna happen in the future. And so I personally feel, and I think we have talked about this as a leadership team at the state, because we don't know what's gonna happen at the federal level, we will have to step up and play a larger leadership role, both in kind of what course of action we take, how we prioritize, and in working with the public to ensure that accurate information is out. That's my own personal feeling, but I think my team probably agrees with me, because in the absence of that federal leadership,
I think this is a great plan.
Basically don't have a choice.
we have to step up and make sure that you know,
Education.
that the public is being served by
Yes.
public health.
Yes.
Related to vaccines. but-
Dr. Curran?
Oh, I'm sorry, Dr. Jane has been waiting patiently
Oh,
to be
recognized.
recognized.
Oh,
No. I'm sorry. I know you've seen me on the screen. Can you hear me okay?
Yes.
Okay. Well, I just wanted to say that I appreciate this conversation that's going on over there about vaccines. I can't tell you how many young faculty members who have young children have written to me just because they know I am on the DPH board about what we are doing preemptively to avoid a situation like what has happened in Florida and what may happen in other states. That their feeling is that we're not like many other Northeastern states where their overall health record is a lot better than ours. And so I'm just wondering what we can do preemptively to make sure that access to vaccines isn't diminished over time in Georgia. And let me ask you a more specific question. Is there something that the board can independently do to petition the governor of the state?
Dr. Jane, I think you have to start by doing a yoga class sooner rather than later for all of us. And I think we'll be working together, board members and my team. We've been talking about that. But I think that we are all very committed to immunizations. As recently as this morning, we talked with the governor's office about it. So I think that there's a huge commitment and understanding of the importance of immunizations, particularly for children, for children's health. And we intend to continue to, carry that message.
I appreciate that, Dr. Toomey. No, really, that's very reassuring. I'm just responding to the email that came out of the DPH regarding COVID vaccination, that we would follow CDC guidelines. And so if CDC starts to put out guidelines that do not,
I can address that because I actually was talking about that this morning. I mean, we are waiting to see if the CDC ACIP guidelines, if it is really out of line with what we feel is appropriate given the science and epidemiologic trends as we know it, we can make decisions then. But it was actually my decision to wait until the ACIP met, because there are other ramifications for their approvals, including insurance coverage for the vaccines, as well as liability coverage. And so, and I think our nurses were more comfortable waiting for that final approval. So it isn't that we are just a step back and say, well, whatever. I think, but we want to take action when there's something we need to be addressing. And right now, we're waiting on that final approval, because there are other factors within that we have to consider.
Got it. Thank you
We
so
don't
much.
have vaccines yet at our health departments. Our orders haven't come in. Remember, we buy through that federal program, and they haven't been shipped yet. So the pharmacies may have shipments that we don't have yet in our health departments.
Our board has 3 of the very best pediatricians in the United States on it.
Hey, and our board has very
Which is
best
amazing.
members. So
Well, thank you, Dr. Karen. I feel that to your earlier comment about pharmaceutical companies moving away from vaccine manufacturing to other drugs and pharmaceuticals, you and Dr. Toomey and I and Mitch, all of us, and Dr. Cheek have witnessed how long it took for pharmaceutical companies to invest in childhood vaccination programs, and the erosion is going to take a very long time to recover from. I'm just ventilating over here, not expecting any response, but my chest feels a little lighter now that I've said it. So I'll
Well, we also depend upon.
I'm putting myself on mute now.
We've been able to depend upon the federal government to monitor the use of vaccines, some of which do cause unknown problems after their license, like the Haemophilus IV vaccine that came out initially and had to be replaced by one that was more effective and safer.
rotavirus.
Rotavirus, I'm sorry.
It's all right. HIB is
Well,
near and dear to my heart.
I think HIV had a problem too, maybe, I don't know.
I don't remember that, but I do remember what it was like without Haemophilus vaccine.
Oh,
And
yeah.
it was shockingly horrible.
And RSV now is available. I mean, so
Yeah.
new vaccines are really important. Dr. Lang.
Thank you. If you've given an update, I've forgotten it, I'm sorry, but what is the plan now regarding grids?
Grits. No, I did not give an update. We are back on track to, and using an updated original grits, because the revamped grits was not working as we had hoped. And we'll be updating it further. And we're hoping, and I can give you a full rundown on that next board meeting.
Thank you.
Yeah.
My
No.
nurses have asked, so I'm
Okay, yeah, so we're back to the, sometimes what's old is new and what's new is old. And that's where we are with grits. And we are, trying to interface that with other EMRs.
thank you.
Dr. Drenzik, are you finished?
I'm so finished. I am so finished. Thank you.
No, I still think, Dr. Jane, that yoga is in order for us.
Megan Andrews.
Yes. It's always hard to follow Sherry, but I wanted to take an opportunity to go over with you all the EMS system in Georgia, which is something that falls within DPH's scope and purview. And I'm going to try and go fast because I know there's also a presentation after mine. So, Frederick, can you go to the next slide? Okay, so this is our statute that delegates to DPH the authority to regulate the EMS system in the state, as well as a reference to our rules and regulations, and then the mission statement of our office. Next slide. So as far as the history of EMS in Georgia, within the statute, the goal of the EMS system within the state of Georgia is to ensure that the programs are coordinated, orderly, economical, and without unnecessary duplication of services. So with that in mind, Georgia's developed a regional zoning process for EMS services to make sure there's not duplication of services within an EMS zone. The second bullet talks about DPH's responsibility over EMS, as well as what we have to consider when determining what the EMS systems should look like. So when analyzing what to do with zoning, these are the factors that the committee's always take into consideration. We're looking at economy, efficiency of the service being proposed, and then a benefit to the public welfare. Next slide. So y'all may not know this, or you may know this, but we do a lot of licensing within the EMS office. So there's really 3 categories that I'll talk about. The first is EMS agency licenses. So these are like the companies that you see, like Grady EMS, Metro EMS. So we license those companies, including their ambulances. They get inspected and regulated by us. So the various license types are listed there. We also license the providers, so the people that work on the ambulances transporting patients. And there's various provider levels depending on their education and training. From EMTRs, which is a EMT responder level, to paramedics, which are the highest level of care being provided. And then the program also does designations of hospitals for things like trauma centers, stroke centers, cardiac. Those are all listed there. And the numbers next to them are the number of designations within that type. So you could have 4 different levels of trauma. So hospitals apply to us. We do all of the work with them to certify them as being a trauma center at whatever particular level. Next slide. So when we're talking about EMS service delivery, there are different types. So there are government-run ambulance services. That's when you see like a county-run EMS crew. There's also private companies that run EMS services, and then hospital-based ground ambulance services. When a provider is selected to run a zone, they can do one of 2 options. They could either be the direct service provider, so whoever is awarded that zone is the one that is actually providing that service. But there's also another structure in place when a zone provider is selected, and then they contract out those services to another licensed ambulance service who's actually responding to 911 calls. So those are 2 structures that exist throughout the state of Georgia. Next slide. So DPH is responsible for ensuring that there is an EMS agency that's responding to 911 calls within every zone in Georgia. There's 159 counties and 175 zones. Primarily, they're going to be county borders. However, there are some counties that have more than 1 zone. They're listed here along with the number of zones that are within that county. Generally, larger counties, some of them that are smaller counties may have like a municipality that is carved out and was awarded their own zone at some point. And then we do have one part of the state where two counties, Oconee and Clark, share 1 zone. However, they have 2 providers that were selected to serve that zone. So they cross over their county lines and work together to respond to 911 calls. The zones themselves, as well as the zone providers, that ambulance that's responding to 911 calls, are all determined through the zoning process, which I'm going to talk about as well. And this is all overseen by DPH, so all falls within our scope of authority. Next slide. So Georgia is divided into 10 EMS regions, as shown on that map. They follow generally our health districts, with some of them covering a couple districts. The regional EMS advisory councils are those local entities on the ground that are designated for reviewing EMS zoning and then making recommendations to the commissioner as far as zoning, whether zoning should open and who that provider should be. Next slide. So who is on these REMSACs that are designated with this responsibility? Well, these are the objectives of that group. Sorry, I skipped ahead to the next slide, but they, as I said, they recommend to the commissioner the designation of one or more 911 providers to respond within each zone. They are also starting to conduct quarterly review of key performance measures to identify potential challenges for EMS response within the region and also identify areas for improvement. Next slide. This is what I was skipping ahead to. So who sits on these REMSACs? They are appointed by the commissioner for the most part. There are several members that are appointed by the County Board of Commissioners. So you can see there, I'm not going to read through, you guys can read who sits on these, but they are all local within that region and work within the healthcare system. Next slide. So the zoning process, as I said, each of these councils is responsible for coordinating, facilitating the improvement of, and maintaining a quality EMS system within that region. So we did start this new process several years ago. I think it was about 2018 or 19. It was when I first started, but these committees will receive, can receive requests from the public or other members of the committee or healthcare providers to review the zone if there's concerns. They'll take complaints and look at the data and make determinations about next steps that need to be taken for that part of the state. There's those 3 criteria, again, that the committee is supposed to look at when they're considering whether to open zone and who to award a zone to. Next slide. So as I said, the REMSAC can receive a complaint regarding a zone, and then these are the steps that they go through in order to determine whether a zone should be open. So the first thing they do when they receive that complaint is they look to see, is this complaint related to economy, efficiency, and benefit to public welfare? There's a lot of people that complain about a lot of things, and if their complaint is, I didn't think so-and-so was nice to me, or I didn't like the color shirt they were wearing, or whatever, they're not going to open a zone for that. So they need to look at the complaint and say, you know, identify whether it falls within the parameters of the statute to consider moving to the next step. If the first answer is yes to that first bullet, they'll move on to the second one, which they will pull the key performance measures for that zone. So the key performance measures are quite extensive. I gave 2 examples here, but they're generally specific to these categories of care that are very time sensitive to make sure that they're getting the right care to the individual and bringing them to the right place the first time. So these are 2 examples. One is about cardiac issues. The second one is about stroke. But they'll review all of those key performance measures to inform the next step of the process, which you can go to the next slide. So when they are done reviewing those data points, they look at whether there has been a significant decline in service by that existing EMS provider? Or is there an opportunity for significant improvement within that zone? And it could be based on all of those factors that we talked about. Then the second question is, can that existing provider that is running that zone address those concerns? If they can, whether it be staffing, different models of care, adding another ambulance, if there is an opportunity for improvement, they allow that provider an opportunity to improve. And generally, we have seen they give them about 6 months to improve. Then they'll come back and meet again and relook at all of those key performance measures after that chance to improve, and then make a decision. If they decide after that they want to open zone because there has not been an improvement after that 6-month trial period, then we move on to the zoning process, which is really, you can move on to the next slide, Frederick. It's very similar to a procurement process. So the regional council, they would vote to open the zone, and then DPH gives notice to all the licensed ambulance services. So, those government ones, the private ones, the hospital-based ones, they're all given notice that zoning is open, as well as the dates for when applications are due. And then we also provide a lot of statistical information about the zone. So things like call volume, even payer source, because the proposals that we receive from those EMS agencies have to consider all of those factors in their proposal. So they'll propose how many ambulances they think they would need to cover that zone sufficiently based on call volume, whether they're going to have more during the day versus more at night, where they would station them around the county, things like that. All of those proposals are received by the committee and they're scored. And that zoning committee, which is a subset of that council, makes a recommendation to the full council. That full council reviews the recommendation and then votes on it. Whatever their final decision is then sent to the DPH commissioner for final review and decision. Next slide. So this zoning plan, these proposals that are received can include changing the zone itself. So two EMS agencies may partner together and say, hey, let's write a proposal where we cover half of the county and you cover the other half. Or other times it could be a municipality that wants, their city carved out. Let's work with a private provider to cover the rest of the county, the rest of the zone, and submit a proposal together. So it could include changing the zone itself. Another factor that is included in some situations is a requirement for a subsidy from the county government. So that's why that data that we provide them is really important, because they see that payer mix that's coming through and whether they're going to be able to be reimbursed for the calls that they're responding to, and can estimate out how much additional funding they would need from the county government in order to operate in a sustainable fashion. So that's something else that's included in the proposals and considered by the zoning committee in making their determinations. Okay, next slide. The next thing is universal issues that we're facing across Georgia as it relates to EMS. So y'all have probably heard the terminology wall times. Essentially, that's when an ambulance shows up at a hospital. They can't leave the patient. It's just
Really sorry. That's on my mind, by the way.
That's so funny. They can't just leave a patient on a stretcher. They have to transition care to the team at the hospital. And at times, especially in like flu season peaks and RMC season peaks, you could see some extensive time where ambulances are waiting.
What's the average wall time?
There's actually a report on our website if you'd like to see it. It varies around the state. I will say the metro area is a little bit higher because just volume of people. But it can vary, and it also varies over time of year too. Like I said, those high-low times are going to be higher wall times. But part of the challenge is that it takes an ambulance off the road, so they're not responding to 911 calls, which then has downstream effects.
It varies, but it varies from what to what.
There's the target.
And
The
what's
target,
average?
the goal is 20 minutes or less.
And
that
what's
is-
the variation?
Have to look that up.
Well, but
Yeah.
it could be as long as hours. Remember
Yeah,
Dr.
we've
Cheek,
heard
when you were
hours.
calling me about the RSV,
Yeah.
when we had so many kids being trying to find adequate transport for
I think
kids.
the lowest I've seen is like 7 minutes.
Yeah.
So 20 is standard.
20 is the goal. Yeah, 20 minutes or less to offload the patient 90% of the time. So that cuts out any of those outliers. So that's a challenge that, we have a committee that was appointed and has been working on that. It has both EMS providers and hospitals because it really is going to require collaboration to work on that issue, to make sure that care is transitioned quickly, and not just the ambulances off the road for 911 calls, they're also out of service for interfacility transports to open up beds in hospitals. So it's
That's gonna be a
creates,
challenge.
right, so it creates this scenario that's just affects everyone. There's also been increases in 911 requests. You hear stories of people calling 911 because they sprain their ankle and don't have a ride to the hospital. So that's another challenge. Reimbursement. If an ambulance shows up and doesn't actually transport the patient, they don't get reimbursed. If they provide care in the home or wherever the patient is. So it encourages transports, but they may not always be necessary. Workforce shortages, you see that across the entire healthcare workforce. That is a challenge. Interfacility transports, as I mentioned, is another challenge. These are either time-sensitive patients or those that need to get to a higher level of care. They need to be transferred to a STEMI lab or something like that.
Let me ask you a question about workforce. I think I sort of think the EMS system is analogous to the air traffic controllers in a sense that we take them for granted if they work. And having a talented, motivated and workforce is so important for the quick transport of very ill people. What about a workforce shortage? Do people, we know there are doctor shortages, there's nursing shortages. How about workforce shortages for EMS?
There is, certainly.
What, do you have any more to say about that? How much is there? Are they adequately paid?
I think that is part of the challenge that I have heard is they're not paid at a level to make it worth it they're a first responder, they're dealing with emergencies and saving lives, and they're not paid at a level that they should be for that, for the most part. So that's a challenge, is retaining them in roles like that when they could go be a nanny or work, at McDonald's, some of them have compared it to, and make the same amount of money. So that's definitely a challenge. I'm sure we have data. I can share a report on that if that's something y'all are interested in. But that's something that we've heard consistently is workforce challenges within EMS.
And then think about workforce throughout the whole healthcare system. If there's a nursing shortage, you're going to have a backup in the ED. And that's going to lead to increased well times, which is going to trickle down the whole way.
Right.
And so I think this is more than just even an EMS issue. It's a whole healthcare system issue that we have to address in a systematic way.
Yeah.
Dr. Cheek?
This is out of ignorance, but I know we used to have volunteer fire departments in rural counties and even volunteer EMS services, I think. Is that still operating anywhere in Georgia?
I believe there are some
I think
areas
so.
of the state that do have volunteer. They're not the designated EMS 911 responder, but I have to get the exact terminology, but they can respond to calls, but they can't transport the patients. But there are volunteer, I want to say it's in South
That would be
East
just an
Georgia
interesting
area.
statistic to know if there's still volunteer.
Yeah.
What percentage
Services
are
out there.
private, hospital-based, and
The vast majority of them are county run.
they are the vast majority?
Yes,
Okay, yeah.
yes.
And who is responsible for the protocol? Is public health responsible for the medical protocol that they are?
They're supposed to have a medical director, each
Okay,
EMS
it's local,
agency.
okay.
Yes, that oversees the protocols.
So it's not as, each director has their own protocol, or it is statewide?
There is.
I'm asking this based on the questions in transporting pregnant people.
Mhm,
So I refer them to the perinatal center.
Yes.
Trying to establish a protocol.
yes.
And our EMS office provides some guidance.
Okay.
And I think one of the reasons, you're probably wondering, why are we talking about EMS at this meeting? It follows in the theme of things public health does. You may not even realize we did, particularly for the newer members. This is one of those hidden
But
activities that really
protocols can
crosses.
vary. Protocols
Right.
can vary throughout the state.
Yeah, and there's,
Although we try to provide some
we do, there's
overarching guidance.
a committee of people, it's called MSTAC, the EMS Medical Directors Advisory Committee. It sits under the state
That
office.
sets a standard.
Set some standards, yes. Obviously, it can vary down a little bit, but they do meet and make recommendations at a state level.
I'm curious, does DPH work at all with DCH from a non-emergency medical transportation standpoint? I know when I was
That's the-
there for any.
That's probably a subject for a different discussion.
Okay.
Because as we really recognize we don't have enough non-emergency transportation in the area of perinatal. I mean, we need to be transporting moms before they deliver, not separately mothers and babies. And so that's something, quite frankly, we are actively working on right now
Okay.
with DCH.
You talked about time-sensitive KPMs, and I think you gave the example like responding in 15 minutes to a stroke
Yes.
call. I hope this isn't silly. How do you adjust for like county density and traffic? I mean, surely that's easier to do in South Georgia than
Or
it is in
distance.
Fulton County.
Well, yeah. I think there's different factors that can impact that depending on where you're located. So yes, in the metro area, traffic is going to be more of a challenge, but you have more ambulances to cover the geographic area. So distance may not be as far, whereas in South Georgia, you may only have 1 or 2 ambulances to cover an entire county. So they're going to have to drive long distances to get to that person. So those are challenges that are different based on geographic part of the state. However, that's part of the EMS zoning plan is you want to make sure that whatever proposals are sent, they can make those goals. So if it's Fulton County, do they have enough ambulances where they can station them around the region to be able to handle those high traffic times of day and get to the patients in time? Same thing for, South Georgia, where they might have to drive, 50 miles to get to a patient. Do they have adequate ambulances to make those goals? We're not like nitpicking. Obviously, like there's going to be challenges and you're not always going to meet your goals, but goals are there for a reason. They're supposed to be challenging to get to because they're going to produce the best patient outcomes. But yeah, that's something that's a challenge.
So is there like a per capita number that you use, ambulance per?
Radius.
We do make some recommendations generally in our zoning process. So one of the examples I can think of is when we had to do this for the Augusta area, looking at call volume, looking at geography. We had some ideas in our mind about how many ambulances we thought that county needed and took that into consideration when all these proposals were coming in on who could provide that adequate coverage. So I don't have like a specific number of mileage, humans, all of that. It's really call volume is really going to be the driver of that because it's actual data and real data we have a ton of data in the EMS system that we're able to pull to really inform decision making.
You must also have variation at the other end, in the sense that as rural hospitals close their emergency departments, you end up with emergency department deserts
Yes.
throughout the state. And if those increase, that makes the system much less efficient.
Right.
But, compared to where your hospital is, even just South Fulton, there's great distances you have to travel to get to a facility. So you have some travel time there that you might not think of in a metro area.
Right.
Thank you.
Yes. And then one more slide. So future trends, these are some things that we're looking at or could see coming down the line. One of them is community paramedicine programs. These are really interesting programs where EMS will go out into the community and they'll do like follow-up care for patients. So post hospital discharge, if they have conditions that require regular care and check-ons, there's programs throughout the state where EMS helps provide that service, which is has been really beneficial. Telehealth use within EMS to assist both during transport as well as through the things like the paramedicine program. Treating without transporting, trying to improve reimbursement for those situations, alternate destinations. That's something that Dr. Toomey worked on a few years ago, really when we were coming out of that COVID spike of really just extensive wall times. Allowing EMS to be reimbursed for transporting to like an urgent care or something like that, if it wasn't an acute emergency that required that patient to go to an ED. And DCH worked with us to help develop some reimbursement protocols for EMS for that. So that was really promoting that is something that is going to be coming up. Telephone CPR by 911 operators, where they instruct callers on how to administer CPR. Tiered response system. So not every call requires the highest level ambulance to go out. You could have a tiered response of, a lower level vehicle that may not be able to transport the patient, but the patient has a sprained ankle, and when they call 911 that they don't need to be transported. So that's something else that a lot of EMS systems are looking at around the state, as well as decreased use of lights and sirens, improving those protocols. Not every transport requires lights and sirens, and it could cause accidents and other public safety concerns. So trying to save those for the true time-sensitive emergencies where people need to get to an ED is also something that is being worked on. And that's all I have. Yes.
I just wanted to comment, I know from GHIN
Yes.
has worked with ambulance services just starting to be able to access GHIN data in a few very small, situations. And that's very important to get so that people know maybe if this person has just been discharged from a psychiatric hospital or if they have had a significant medical problem that they cannot physically say, or not, there's no one there to kind of give enough healthcare data. So I think in your future trends, the more institution of mobile units that have access to GHIN and GHIN data is certainly appropriate. And I think there's an ongoing pilot that's happening right now
Oh, that's interesting.
with that.
Good to know.
Thank you, Ms. Andrews. It was
Yes.
enormously
Enormously.
informative.
Yeah.
And,
Okay, good.
we all learned so much.
Oh, good.
And,
That was
it's
a lot.
reassuring to know that you're on this.
Oh, yes.
That's a lot.
Yeah.
She knows the most about EMS in the.
Not the most, but.
Certainly on the 19th floor.
Dr. Kirsch, finally.
Thank you. May I have my slides? I don't know how they come. There you go. So thank you again for allowing me to speak here. I'm delighted to be here. Next slide, please. I don't know who does the slides and where they are. So I've already introduced myself, so just very quickly, in the interest of time, I've been the lab director since July, so fresh in the job. My education was in Germany, and I came here for an internship at Washington University in St. Louis, where I then also got my PhD in biomedical science. Came to Atlanta first for Emory, and then have worked at the CDC for 18 years. Of note, during that time, I spent a year in Washington to work on HHS testing issues during the COVID pandemic that had to do with supplies, test regulations and also working with state laboratories specifically on their needs during the pandemic. And I'm certified through the American Board of Medical Microbiology as a diplomat.
Could you write a book about that year?
You know, it was the honor of a lifetime. It was actually, yes, I could write a book, including things that were never in the press. Like, I mean, the military, you know, ran like planes overnight to get us pipette tips and stuff like that. It was just amazing. But anyway, in the interest of time, next slide, please. So what I'm going to talk about is just some facts about our laboratory and where we came from, projects we have recently started and where we're trying to go and how we plan to capitalize on these projects and some grants to deliver value for Georgia. Next slide, please. So I thought I'd start with our mission. It is to provide accurate, timely, and confidential clinical and non-clinical laboratory testing services, just to support the department's mission, which is to prevent disease, injury, disability, promote health and well-being, and prepare for and respond to disasters. And the vision, of course, as you know better than I do, is a safe and healthy Georgia. Next slide, please. So the Georgia Public Health Laboratory really is two laboratories. Our main location, of course, is in Decatur on Claremont Road, where we offer 115 orderable tests to support patient care. And then the Waycross Laboratory in Ware County is a smaller facility, but also beautiful, which currently offers 10 orderable tests for the Southern Health Districts. So overall, our testing portfolio is, of course, newborn screening, which is a heavy focus, where we offer 35 tests. Then our microbiological testing services, which really span most of microbiology, so influenza, measles, TB, the STDs, and so forth, also more esoteric diseases. And then we also offer environmental health and emergency preparedness, where we test things like chemicals, like fluoride in your water, but also white powders, bioterrorism, opioids, and other chemicals. Next slide, please. So we try to align what we offer and what our functions are with some guidance that was put out by APHL, the American Association of Public Health Laboratories, which published this document for state laboratories specifically. And I list here the main functions, and I'm proud to say we cover all of them. So of course, we do laboratory testing for disease prevention, control, and surveillance. And we also offer a lot of reference and specialized tests that counties cannot offer. We participate in emergency response, environmental health and protection, and focus heavily on food safety. We do consultations and also serve as a repository of laboratory improvement and regulation. We've just come from a few years where with very heavy activity after COVID-19 with new regulation and help with policy development for other labs. I'm surprised to say how much integrated data management goes on in this lab. Just across the state, receiving and giving test results is complicated. We do a little bit of research more on the developmental side, and we do training, education, and partnerships. Next slide, please. So here is a graph of, to give you a flavor of how many specimens and tests we do. So deliberately here, I cut this off after the pandemic, so more normal times. In the last fiscal year, we received 360,000 specimens. Most of them have multiple tests on them, so we were able to report 8.6 million test results last year, which is quite respectable. And then most of the largest specimen submission is for newborn screening. Every baby in each one has 35 tests, and that's how you come with these numbers. Next slide, please. So speaking of newborn screening, it is definitely the majority of what we do, about 60–70%. So all newborn babies in Georgia, of course, are promptly tested for certain conditions that pose a threat of severe illness, and most of them also where an intervention is available. So we screen for 35 disorders, and we offer this to all babies in Georgia. And in fiscal year 25, we performed 150,000 such tests. Of course, there weren't 150,000 babies, it was closer to 127,000, but multiple of them have to be repeat tested by us. And also some quality control testing is included in that number. So it really is the largest portion of what we do. And only our lab does this in Georgia, so there is really currently no alternative. Next slide, please. Very briefly, those are the 35 tests that we currently offer. And of course, this is done on a heel prick and then comes to us on a dried blood spot. I won't go through all these diseases, but just to know that there is a committee that recommends these, and that's how we select these diseases to test for. Next slide, please. So just very briefly, what this accomplishes every year from our annual report that we do with our EPI colleagues together. Of course, the screening program also has some heart disease and hearing testing as well. And these programs identify in 2024, 545 babies that needed intervention. And of those, about 320 or so were diagnosed in our laboratories. So those are lives that are either saved or are substantially improved by our services. And we're very proud of that, being able to provide that. Next slide, please. And then again, we also work on emergency preparedness in microbiology. We are a host of the BioWatch program, which does environmental sampling for bioterrorism. And we do have permission to work on select agents and have the facility for it. So these are substantial contributions for Georgia's preparedness and biosafety, and provide us some independence from reliance on just federal services, and allow us to serve should there be such an event. And then again, for infectious diseases, the fact that we offer that on a state level and not just in large hospitals or at CDC, it does ensure that our citizens here have rapid access to those highly specialized tests and can send those to us. And both of these programs also have a huge role in enabling the department's participation in federal grants that require laboratory services. Next slide. And speaking of federal grants, so our laboratory receives upwards of 20 federal grants or participates in them. And I'd like to spend the remainder of these slides and talking about a few selected grants that have been, shaping what we do in the lab and are worth highlighting. So they'll be on workforce development, and we just talked about that for EMS, the same in laboratories. And then the EPI and lab capacity building that Cherie also knows a lot about, where we particularly focus on advanced molecular detection in the laboratory. And then also a grant we received for genomics and incorporating that in our work. Next slide, please. So like EMS, the laboratories across this nation had a hard time after and during COVID having enough workforce and people that have the right training and credentials and certifications to perform clinical microbiology, which is a regulated part of laboratory landscape. Next slide. So for example, in January of 25, our lab leadership team had several open positions that are critical for us. So the director position was open, but also the three leaders of our sections, microbiology, emergency preparedness, and newborn screening were all vacant.
Golly.
Right. Next slide, please. And I'm happy to say that as of September this month, we filled 3 of these positions, and we're currently interviewing for the microbiology department. So Eduardo Gomez was recruited from CDC for emergency preparedness, and Shireen Amir has a medical background and leads our newborn screening lab now. Next slide. We also completed a building addition indicator. So this was a CDC grant-funded activity. We received $28 million for this after COVID, specifically for capacity building. This added 11,000 square feet of laboratory space to our building. It's in the back of the building, so if you drive on Claremont Road, you probably have not seen anything, but there is a whole new addition behind the building, and this is just a picture from when this went up. So we have 2 additional biosafety suites. We have dedicated space for genomics and sequencing, and we also have a new training facility, and we're very proud of that accomplishment. Next slide. So now I'd like to get to the last part of the talk, and what Dr. Toomey asked me to talk about is the vision for our future. So I've started this job just 2 months ago, and really the first few months, I really want to just listen to our customers and stakeholders so I can be sure to orient our laboratory towards what the needs actually are in Georgia and to the places that submit specimens to us and to the Department of Public Health. A few things that I've already heard and have started to work on implementing are listed here. So we're definitely focusing a lot on quality improvements. We are investing heavily into better specimen chain of custody issues and electronic test ordering systems. We're implementing 2 new web portal-based systems to better track our specimens, our test results, and turnaround times. We're doing a big budget analysis currently to find efficiencies and to also be ready should there be changes in the grant funding landscape. We've got a lot of COVID money that is definitely ending, so we're trying to get ready for that. I'm working on considering a clear role for the Waycross Laboratory. It is positioned in rural Georgia and could serve in that region with more testing. And then I want to give a few examples of how we're trying to modernize some areas of our lab, and that'll be in the next slides. And then just also we'll briefly mention how we are focusing on training and customer support. Next slide, please. So I brought 3 examples of modernization that is going on in our lab. And the first one was another grant we got that is starting to bear fruit after an initial investment. So this was a CDC grant that our laboratory received for $17 million. It's an investment in the infrastructure that will allow us to use more genomics for pathogens in other areas in our laboratory. Next slide. So this is one of only 5 such centers in the United States. So it's a big achievement that our laboratory was able to receive those funds. Next slide. And I'm just going to give a few examples why we're excited about this and how we think this will benefit Georgia. So here is just an example of how genomics was used in recent outbreaks. I just picked the example of COVID-19, where we've all seen in our work how these different variants of COVID needed genomic sequencing, and that really needed a bigger investment in the data storage systems, data transfer systems, and also dashboards where public health can really access and collate these data at a central level like a state public health laboratory. And we're ready to do this now better than we were during COVID with this investment. And I do think this will allow the state and Sherry's work to prepare based on, the latest strain and what disease characteristic it has, if it needs more hospital beds or more testing supplies and so forth. It's really a resource that we can use for that purpose. Next slide. Another example where we've used genomics is really for source attribution, for example, in food safety, or we had a recent work in a hospital infection control issue. So this is a picture of a food safety issue, an E. coli outbreak, where we were able, this is not our work, this is just from the literature as an example, where public health was able to just sequence the samples of several people to determine if they're all the same. So in this genomic tree. If something is close together, it just means it's almost an identical sequence, and these are all the same strains, versus when it's further apart, you know that you have multiple individual infections that just arise independently. So in this example here, that would be an example of an outbreak where there's probably one source that you need to find and eliminate to control this infection. Next slide. And lastly, we will be using more genomics also in newborn screening. So this will replace outdated tests, and we hope this will give greater specificity and reduce the need for repeat testing, which is costly and also very stressful for the family if it was a false positive and they have to come back in and get tested again. So this is just also a generic example where you can see how these cards come to our lab and we punch them out, and the traditional method would be on top here, where you look at the proteins in mass spectrometry, and you can see immediately in this picture that has low specificity, has a lot of errors, you have to repeat it. And if you use genomics, like here in this example, PCR, and you specifically look for one mutation or a series of mutations, you can really achieve greater specificity. And we're starting to use this. Our first test will be cystic fibrosis testing, and there's a whole series of other tests that could benefit from this. Next slide, please. And then this is my last content slide. Again, both our genomics grant and our building edition grant had monies for training support. So we're very proud to now have in each of our labs a whole dedicated room just for training that has the right outfits. And we are getting requests from other public health labs in the state, from CDC and academic partners to use these spaces and to come to our facility and be trained. Next slide. So I just want to thank Dr. Toomey for giving me this amazing opportunity. It's really been so awesome to get to work on so many different diseases and issues. I'm really excited to be here, and yeah, just thank you.
Welcome. Thank you. Any questions or comments for Dr. Krush?
Very good.
I have one. Everybody should at least have one question.
Yes.
You mentioned there are 300 people that are detected for further follow-up through the lab each year, approximately. Do you have any way of knowing how timely that is and whether or not it's effective? I'm thinking about, the relatively sporadic care for many people after they leave the hospital.
As a pediatrician, the public health has been wonderful throughout the years in basically tracking down that patient. We get anything that's abnormal. I mean, whether it's just a thyroid screen, which is usually we don't get a call about that one, but anything that is outstanding and it's our patient or they've left the hospital, they start tracking down that family right away. And if the most, babies don't leave the hospital without a follow-up plan, they usually identify where they're going to. And so the mother may or may not show up, but most of the time she does. Most people are concerned about their children, want to take care of them. So I don't think it's as hard as it would be if it was just, the general public and not knowing where their healthcare providers are. But most babies are born in a hospital. Most babies have a follow-up plan. And public health calls us right away if there's something that pops up that's bad, that has to be dealt with within, days, or the child could have an organic, problem and,
So
life-threatening event, basically.
I'm thinking that, there's a lot of people. I mean, I'd like to know about all 300. In other words, how many fall through the cracks, if any? I would say a baby's born without prenatal care. They go to they're born at Grady or someplace, and then you get back to Grady or Hugh Spalding or someplace or show any place, and you say, here's the result. Do you actually go out and find the people yourself, or make sure they have a pediatrician, or make sure they actually come back in, or, because the people have to be contacted, then they have to actually come in and see the doctor for follow-up.
And I can just say, in my time here, the only time I know, there have been several cases where there have been, children have been missed. It's because the specimen didn't make it to the lab for some
Oh.
reason. And so the problem wasn't the laboratory losing the specimen or not processing it in time. It was that the specimen itself didn't make it to the lab for whatever reason. And that's why, as we're working now and improving Dr. Kirsch, bless her heart, is working on the courier service, among other things, and working with hospitals and to ensure that everything is obtained at the laboratory and processed in a really timely way. So, but I, as I said, in my tenure here, we have had some kids, including PKU, which is heartbreaking. But that was because the specimen itself was somehow lost in transport.
You know, every baby has an identified doctor, you know, somebody's going to check them out in the hospital, and then that identified doctor is going to identify where the baby's going. So there's a pretty good chain and pretty easy, not easy,
Even if
but
they have no prenatal care, they get an identified pediatrician.
And then the pediatrician has to contact them to make sure they come in.
well, yes.
And public health will help track them down too.
And public health is going to track us down
Yeah.
to tell us that we're looking for this baby that has this. It's got to get to your office. And if it's not getting to our office, we're looking. So there's a lot of people, you know, especially for a critical situation.
Good.
There's people looking. I mean, I guess it could happen, but in general, that's probably a safer net than just the general public net of trying to run down an adult with a problem.
And I will say the slide, I went over it so fast, but there was one statistic on there. How many are first contacted? It was 7%, and then 4% are actually diagnosed positive. So there is 3% that get retested and then don't have that condition.
It's very impressive. It's amazing because it's a huge system.
Yes. I'm impressed with it myself, you know, I'm new to it. And we also work a lot with Emory. There is a dedicated team there that, you know, for the follow-up testing, it's very impressive. I agree.
Does anybody have any more comments for Dr. Kirsch or for anybody else or anything about anything?
I have a data-related question. I'm curious about the technology. You mentioned your integrated data management. Do you know what you all are doing to warehouse, what you're using to warehouse your data?
For the newborn screening, we just switched 2 weekends ago to a cloud-based. We still had a thing,
On-prem.
which was, I was told on my first day of work, this is a single point of failure. You know, potential, and we need to not delay this, which we managed to do.
Okay.
Yes.
And since you are part of our team, we can make sure that you are aware of this.
Yeah, I'd love
Because
to know.
it's certainly relevant to vital records.
Yeah, Gabbers is
Exactly.
popping along.
Gabbers, my favorite system.
Limping along.
I'll make one comment. We talked about this before the meeting started, but I got this at my last meeting about the success of the home visitation. And this needs to be a public service, good information for the public health department. I mean, this needs to be an article in the paper or something.
We're working on that.
Good. So it's a good, I mean, you look at the state of Georgia and what you've done, I mean, just that graphic right there.
Yeah.
Is huge success. You know,
Moving up to 75.
especially when we worry so much about below maintenance. This is the only program that is addressing that.
For people that are new, it shows that some board members can make a difference. So it's been a very informative meeting. The first one I remember in my years on the board that we've actually gone past 3:00. A lot of times people, sit there, watch for 2 and they think they're going to get out of here at 2. But that's because we had so much great new information from everybody. So I'd like to thank everybody for that. Do we have a motion for adjournment?
So move.
Second.
All in favor?
Aye.
Say goodbye to the people who are online.
Yeah.
Still there?
Thank you.
It's the first time Mitch Rodriguez hasn't said anything.
He's smirking.
turning this off?